welcome to everyone who has joined this virtual update event for the National Neonatal Audit Programme. You're all very welcome, and I have to say, I think this is the biggest attendance we've had for one of these events. It's also great that so many people from a diverse range of team members for the perinatal team have been able to make it today. We know we've got obstetricians, midwives, pediatricians, neonatal nurses, and so on and so on, which is fantastic because the care of very premature babies doesn't just start at the moment of delivery, and having that continuation of care across the period of the perinatal events is so important for optimizing outcomes. What we're going to start with today is the latest findings from the NNAP annual report from the 2019 data. And that'll be led by Dr. Sam Oddy, who's our NNAP clinical lead. Sam doesn't really need any introduction from me, other than to say that he hails from a place a bit further north from here called Bradford. And he does what he does extremely well, as we all know. Then after Sam, we've got Dr. Julie Claire Beecher, who's the quality lead for the British Association of Perinatal Medicine, who's going to talk to us all about optimizing the perinatal pathway and the antenatal optimization toolkit. And I think this is going to cover things both before, during, and after birth, and hopefully that will be something we can all take home and apply in our units. Finally, Sam will round up with the future of the NNAP session, and then there'll be Q&A from around about 3:30 onwards. Unfortunately, I have to duck out at about 2:30 as I've got a clash, but I will leave it with Sam and Jess, very capable hands to take this forward. And whilst I've been very kindly given 10 minutes for introductions, I find that I have managed to rush through them in my usual precipitous way in 3 or 4 minutes. But I think that's even better because it allows Sam and Julie Claire more time to tell you about the important stuff, and you don't have to listen to me blathering on anymore. So without more ado, I will hand over to Sam to talk about the National Neonatal Audit Programme. Sam.
Thank you. Hi. So welcome, everybody. Can people hear me? Somebody waved to check they can hear me. Ah, look at that. And I've had a quick scroll down through your pictures and images. How lovely to see so many friends and colleagues, friends all and colleagues from around the country. Nick slightly understated it by saying this is the biggest launch event we've ever had for a report. And the last time the college hosted a launch, there were about 25 people there. There are apparently over 200 people registered for today's event, so we're delighted by that, and thank you for joining us. So I'm going to try to summarise some of the results of this year's report for us today. Not all the results, and I'm actually going to do that across both presentations in a way that I hope is helpful for you. So if you only want to find out about mortality, nurse staffing, and breast milk feeding, come back for the second presentation, but hopefully they'll both be of interest. So in this first thing, I'm going to try to signpost you to NNAP online, which Jess might be able to tell us, I'm hoping is now live. Jess is muted, but she might be able to tell us whether it's actually live.
It should be live.
Fantastic.
And I did ask for that, so I'll check that and make sure it is.
So those of you who've got 2 screens could be looking at your own results at the same time. I know that's the way you all work. So I'm hoping also that we can enlist your help in reviewing the key findings and delivering the recommendations to the target groups. So without further ado, I'm going to kick off. I know that we all know that NNAP is not just about very preterm infants, the babies that are less than 32 weeks, but those babies are represented here at the top. And we aim to discharge those babies home alive and to find them unimpaired at 2 years of age with no difficulties. But between those 2 outcomes, There's the sad possibility that some of the babies will die, and some things represented in red ellipses, bad things that can happen: infection, NEC, BPD, formula feeding, brain injury. And we've got some things, some blue ellipses: antenatal steroids, magnesium, deferred cord clamping, being delivered in the right place, the right temperature, interventions, and most importantly, having enough nurses to allow to get the best outcome for these babies and look after the families in the meantime. So I'm going to kick straight into some of those measures. We all know that NNAP have got a measure about whether a mother who delivers a baby between 23 and 33 weeks gestation, does she get at least one dose of antenatal steroids? And broadly speaking, the answer to that question is yes. About 92% of eligible babies received a dose, mothers received a dose of antenatal steroids. And here we see a caterpillar plot. So on the vertical axis, we've got the proportion of women who received a dose of antenatal steroids whose babies were admitted. And along the horizontal axis, we've got the neonatal networks represented. And you can see that the London Northwest Neonatal Network do very well at this. And there's a little bit of spread between neonatal networks. The light grey spots, so here, for example, in the northern region, with a measure of uncertainty around that spot, that's 2018 rate, and in 2019, significant improvement, and many networks show important improvement in this. So I think this is really encouraging. This is assurance. This is showing the system that we're using antenatal steroids in a widespread and effective way. So we convene, or the college convenes groups to decide what this data means, to decide on the key findings, and to make recommendations based on those key findings. I want to try and point some of these out to you. These are very much thought through and considered, and come from a very multidisciplinary group. Recommendations made include that neonatal units and obstetric service, the perinatal team, should optimize the timing and dosing of antenatal steroids whilst avoiding inappropriate use of multiple courses. And adopt the following evidence-based strategies to predict preterm birth. So the BAPM, perinatal optimization, which JC is going to talk about, and SPSP, Scottish Patient Safety Programme. The group were also keen to recommend that National Maternity and Perinatal Audit could consider developing other reporting of antenatal steroid use in order to encourage timely administration to eligible mothers. So antenatal magnesium sulphate, after precept, we all know, we perhaps all knew before, that antenatal magnesium sulphate reduces the chances of babies being born below 30 weeks, certainly, and some more mature infants, of developing cerebral palsy when they're older. So the question hidden by your video for me is a mother who delivers a baby below 30 weeks gestation age given magnesium sulphate in 24 hours prior to delivery? And the answer is that we're doing significantly better at this. So here we see a caterpillar plot, again, vertical axis 0 to 100%, and the individual neonatal units represented along the bottom. And you can see there's the neonatal intensive care units, which tend to be larger and so have smaller confidence intervals than local neonatal units in blue and special care units in grey. You can see that all kinds of units have all kinds of performance at this, but in general, we're approaching, on aggregate, the developmental standard, which was arbitrarily set at 95%. It's really impressive when you look at the neonatal networks and how they've changed over time. For example, let's take London Northwest on the right-hand side of the plot. Even London Northwest, who were already very good in 2018, have made a significant shift. And on average, across the country, we've improved by more than 10%, which is pretty exciting. So we're doing really, really well. There's a bit of variation between neonatal networks. Some neonatal networks seem to be able to manage on aggregate more than 90%, and other neonatal networks not quite so good. We take this as supportive evidence that England have done better than Scotland and Wales, and that might be indicative evidence of precept's effectiveness, because that precept didn't run in Scotland and Wales. But really, really encouraging how well we've done, and we hope this will be sustained during this challenging year of 2020. So I'm going to skip over that. And as you'd expect, we've made some recommendations that neonatal units obstetric service should work as a perinatal team to ensure that women are offered magnesium sulphate where that's possible, and to adopt appropriate guidance and methodologies to drive quality improvement where that's appropriate. So we know too that the least mature babies benefit from being delivered in services where there's an on-site neonatal intensive care unit. And so we have a measure for that in the National Neonatal Audit Programme. And this caterpillar plot shows us for each individual neonatal network, the proportion of babies of less than 27 weeks who are delivered in a hospital with an on-site NICU. The two neonatal networks on the right-hand side, I think, would probably acknowledge that their structures make it much easier for them to meet this standard. And there's a lack of clarity about whether their structures are configured optimally. I know Scotland are proposing to have less neonatal care units in the future. But you can see this wide variation between neonatal networks, and not much improvement from 74% in 2018 to 77% in 2019. So the key findings and then the recommendations, which I thought was actually really quite disappointing. And people felt really quite strongly that this was something that needed to be addressed. So some fairly strong recommendations were made, targeted at departments of health in England, Scotland, and Wales, and that those departments of health and the neonatal network should prioritize structural changes in operational management to ensure that babies who need intensive care delivered in the right places. And further, and this was quite striking, but clearly based on experience of the professionals who made these recommendations, that local maternity systems and their equivalent bodies in developed nations should ensure that appropriate clinical pathways exist. And by that, they meant, are we clear in every neonatal unit in the country that isn't an intensive care unit, how less mature babies should be antenatally transferred, how that's facilitated. So the clear pathways exist. So we could talk about temperature. Everybody who's been involved with NNAP for any time knows that we're keen to measure the temperature of the babies, and it was the first of BAPM's quality improvement toolkits. The measure is, does an admitted baby born at less than 32 weeks gestation have a first temperature on admission, which is between 36.5 and 37.5, and measured within an hour of birth? And the answer is that we're, on aggregate, pretty good at this. So here's a caterpillar plot. On the vertical axis, 0 to 100%. On aggregate, we manage this nearly 3/4 of the time, 70% of the time. But look at the variation between units. If we just do an apples to apples comparison, comparing the neonatal intensive care unit on the left, manage that less than half of the time, and neonatal intensive care units that can manage it almost, well, over 90% of the time. So very impressive. Neonatal networks too, really interestingly, vary astonishingly with respect to this, from 60 to 80%. Thames Valley and Wessex have got a long history of being excellent at keeping their babies warm. It's striking that some neonatal networks have really improved between 18 and 19 in this highly objective measure. And this shows that we can make stuff better if we try hard. So for example, East Midlands, Southwest Neonatal Network, to some extent my own neonatal network, and others have really improved their thermoregulation. Did I mention East Midlands? I meant to. We can make things better, and we think this is 3% better than last year. We think this is still a best in the world figure. So we do really well at this as a country, but we can still improve further. You can see over the years, this is an apples to apples comparison. We're continually improving by about 3% a year. And importantly, the proportion of babies with a temperature of less than 36 has declined from about almost 1 in 10 to more like 1 in 30. So very exciting. We should be encouraged by what we've done. You don't just need to look after the baby well. in order to look after the baby well, you have to look after the parents well, and that involves making them partners in care. So we have this long-standing measure of, is there a documented consultation with parents, between the parents and a senior member of the neonatal team within 24 hours of a baby's admission? And it's any admission. The answer is, well, mostly yes. We manage this on aggregate, on average, about 19 times out of 20. And you can see that neonatal units of all levels are good and bad at this. So there are neonatal intensive care units that can manage this 100% of the time, and there are neonatal intensive care units that don't do nearly so well at this. And one of the things about this is that if you do averagely well and don't improve, then you get overtaken by the pack. Ask me how I know. Neonatal networks vary significantly. Thames Valley and Wessex, again, excellent at this. But you can see here from the number of neonatal networks that differ between their grey spot and their black spot, how many neonatal networks have really improved and helped drive the standard upwards, and potentially leaving people who are failing to do continuous improvement a little bit behind. There were 5 neonatal networks were the lowest performing in 2018, and 4 out of those 5 have managed a really significant improvement. So that tells us that we can get better in large groups and improve things. So recommendations, the units are urged to reflect on their rates of parental consultation. Do they think it's a problem? I think we can own in my own unit that it is a problem. And then to use a QI approach and consider using alternative means such as video calls when parents are not able to enter the neonatal unit for any reason. And this is all about parental partnership in care, of course. So, not finally. On-time screening for retinopathy of prematurity. We know this prevents blindness. The audit question being, does an admitted baby weighing less than 1,501 grams or less than 32 weeks gestation undergo their first ROP screen in accordance with the NNAP interpretation of the current guideline recommendations? And the answer is kind of, 19 times out of 20. It's frankly surprising, almost shocking to it is shocking to our parent representatives that we can't just get this right. And significant frustration was expressed in the guideline groups about, in the key findings and recommendation groups about this. Why is it that we can't just sort this out? It's got to be said uncomfortably that there's a neonatal network that is a low outlier for this and has been a low outlier before and a year before that. But there is no network that manages 100% of the time. And it's worth saying that the units at unit level that can manage this 100% of the time, that proportion is getting wider and wider. There are more and more units that can do it 100% of the time. Most of there are 1% of babies, so 1 in 100 babies are never screened at all. There's no evidence they were ever screened. And of those never screened babies, 10 were less than 30 weeks gestation, so at risk of life-changing disease. Of the babies who weren't screened, they're mostly in neonatal intensive care units. So there was a view, perhaps this is because of poor ophthalmologist availability in smaller neonatal units. That isn't the case. So there's stuff that we can do to address this, and it's not all about data quality. So some fairly strong recommendations made, and in fact, these were not as strong as in the first draft. We think intensive care units in particular have got a responsibility to have a system to identify and treat and screen their babies, and safety systems to make sure that those work. And that neonatal networks have got a role in actually having neonatal networks with low rates of ROP screening should have a mechanism for real-time measurements of their units' adherence to ROP screening guidelines, so that something can be done about it. Because there are a couple of networks in particular where it's clearly an issue. So bloodstream infection and central and associated bloodstream infection are 2 things we've been measuring for a little while in NNAP with increasing success. So the audit questions that I would draw your attention to: does an admitted baby have 1 or more episodes of bloodstream infection characterized by a positive blood culture after 72 hours of age. And we have a central line associated bloodstream infection as well. The interpretation of this data is complicated because of the necessary changes in methodology. So the denominator is just slightly different, concentrating on babies who are present at 72 hours of age or afterwards. And we've improved and clarified the list of what constitutes a clearly pathogenic organism. So we would all accept that a Staph aureus or an E. coli or an Enterobacter cloacae species, that they were clearly pathogenic organisms. And we've defined a list of organisms which is available in the report. So the other challenge to this measure is that in measuring infection is only a valid thing to do if a unit can confirm that all its positive blood cultures have been submitted to the audit. And this year, just less than 2/3, 63% of the neonatal units participating in the audit confirmed that all their positive blood cultures. That's a little bit worse than 2018, for which I think we reasonably blame COVID, which was just kicking off at the time. However, if you look at at unit level data, it's really quite concerning. For example, amongst the neonatal intensive care units with complete data entry, between 0 and almost 13% of babies less than 32 weeks experience one or more positive blood cultures with a clearly pathogenic organism. This is not likely to be explained by case mix. This represents real variation in quality. And I know neonatal units are taking this seriously already, but I think there's more that we can do as a community. I'm going to skip over the CLABSI findings and take us to the recommendations. So it's suggested that we do more than suggest, we recommend that neonatal units with higher reported rates of infection should compare their practices to units that have got lower rates of infection identified by NNAP online, and ensure that their use of evidence-based infection reduction strategies is optimized. We also thought that neonatal networks and units with both low and high rates had a responsibility to facilitate invitations, to facilitate that cross-fertilization of knowledge between units, so that visits, whether real or virtual, could take place, so that people understand the differences in practice and implement potentially better practices. These visits clearly need to be multidisciplinary because this is a multidisciplinary problem. So, a further important complication of prematurity, bronchopulmonary dysplasia. We define that as oxygen dependency at 36 weeks gestation. And the rates of BPD, perhaps unsurprisingly, vary very strikingly between neonatal units. This is neonatal units of birth. You can see they vary from around 10% to around 60%. And the logical response to this, correctly from neonatal unit colleagues, was this is because of the kind of babies that we look after. And for reasons that some of you will be familiar with, because it's not the first year we've done it, we've done some case mix adjustment, what is in effect case mix adjustment, to try to understand why this occurs, why there's such variation. And the bottom line, and so I'll just further make the point that the pink units, which are the neonatal intensive care units, tend to be on the right-hand side of this plot, so tend to have higher rates of BPD. And of course, neonatal intensive care units look after higher risk babies of less than 32 weeks. So that explains some of the difference. But we've conducted what we call a treatment effect analysis. So what this does is ask, based on characteristics that we record in Badger, how it would be that for a given unit or network, how the babies in that unit or network would have got on if they were looked after in the wider population. And the difference between the calculated rate of that, how those babies would have got on it in the wider population or in the unit, becomes the treatment effect. So in effect, on the left-hand side of the plot, there are units with a negative treatment effect. And that means that babies looked after in those units appear to be significantly favored and have a lower rate of BPD. And that doesn't just include some local neonatal units, includes some in neonatal intensive care units. There are in fact 8 units with low outlying treatment effect for BPD. On the right-hand side of the plot, more concerningly, just as interestingly, there are 16 neonatal units with high outlying treatment effect, suggesting that being looked after in that neonatal unit is more likely to result in a baby being diagnosed with BPD. So this is pretty powerful stuff. It's not so new. We have identified outliers statistically, but not published them. We'll willingly discuss that more with people. So this is the same thing for neonatal networks. And isn't it fascinating that it varies by neonatal network to a very large degree? So the raw rate of BPD varies from around 32.5% to well over 40%. And there's a striking variation between networks. We can do the same treatment effect analysis, showing that being looked after in some neonatal networks is associated with an increased risk of death or BPD. It's a combined analysis of death or BPD. And there are some neonatal networks where that looks to be, there's importantly less a negative treatment effect. So we hope this is useful information. There are some recommendations that go with this. Neonatal units with high treatment effect should clearly be seeking to identify potentially better practices from neonatal units with lower treatment effect, with low treatment effect. And neonatal units and networks should seek to understand the extent to which care practices do explain the variation and implement any potentially better care practices, including those from the NICE guidance on specialist respiratory care. BAPM is a charitable body, but the participants thought it was reasonable that the BAPM would consider developing a care pathway, identifying potentially better practices that might impact on BPD. And so I imagine BAPM will consider that. So I'm getting there through the outcomes. Necrotising enterocolitis. This is a terrifyingly bad outcome of very preterm birth. The question being, does an admitted baby born at less than 32 weeks gestation age meet the NNAP surveillance definition for necrotising enterocolitis on one or more occasions? And the answer is about 1 in 20 babies were diagnosed with NEC according to this definition. There's more to do here. About, just under 2/3, 64% of neonatal units confirmed their NAC data were validated. That's just slightly less than happened in 2018 and is, again, probably a consequence of the COVID epidemic. But even despite that, rates of NEC do appear to vary between neonatal networks by as much as 2-fold. Now, this might be because of some missing data, as high as 13% in one network, but it's not likely to be wholly explained by case mix. Our key findings group pointed out excellently that when neonatal networks think about their NEC rates, they should consider them alongside their mortality rates, because it appears that rates of NEC are lower in networks where mortality is higher. I think this is a quality journey in progress. We've got more to do to deliver high quality data. Just over 5,000 out of the 7,500 eligible babies were in, and most of the NICUs, but not all of them, validated their NEC data. The missing data is well down. So in general, more to do, but we're getting there. So some recommendations. I'm going to skip over those for now, because it's time I got off, I'm sure. Follow up at 2 years of age. In order for us to describe, to deliver what we all want to, healthy babies and discharge from follow-up at 2 years, we need to actually know whether they are healthy babies. And there is, as we all know, a national standard, and in fact, NICE guidance describing what we should do for follow-up. And yet we can't be confident that we are doing it. Yes. Does the audit question being, does a baby of less than 30 weeks gestation get medical follow-up at 2 years gestationally corrected age or not? And the answer is not really. So in the blue columns you can see on the slide, over some years, any information recorded at follow-up, we're not doing great as a community with respect to this. We can do better. We have the developmental standard set for some reason at 90%. It's a developmental standard. Perhaps that's our excuse, but really we should all be aiming to do this 100% of the time, which is what we would do if it was our own child or our own colleague's child. Neonatal units vary greatly in their delivery of this. There are a small band of pioneers on the right-hand side of the plot who deliver follow-up to 100% of their babies. And it's noteworthy that that includes units of all types. It's not just special care units. It's not just local neonatal units. It includes neonatal intensive care units. And then on the other side of the plot, there are neonatal networks, neonatal units of all types, special care units, intensive care units, local neonatal units, who deliver follow-up to a much lower proportion of their babies. And that's not really great. If we look at the caterpillar plot, we can see that some neonatal networks have made important improvements in this. I'll big up Yorkshire and Humber because that's where I work, although Nick, I am a reformed Londoner. There's one neonatal network where there's been an important drop in the recorded follow-up information. So I think we know as a community that we can do better at this, and we're going to continue to get pressure from our commissioners about this. So there are some detailed recommendations based on NICE guidance that we need to consider the arrangements for communicating with families about follow-up when we discharge them, make plans for families who live a long way away from the hospital, deal with the families who don't attend appointments and families who move, and completing and documenting the assessments. We've got a new partner in this, the British Association for Neonatal Neurodevelopmental Follow-up, BANFU, and we hope that they will describe and promote best practice and successful models of delivery of high rates of follow-up with appropriate instruments. Because I think there definitely are examples of us being shown ways to do this better. So I'll conclude my presentation by encouraging you to look at your unit level results on NNAP Online, which is now live. We hope you'll use the results that you find on NNAP Online in writing your unit quality improvement plan. And we hope that the key findings and recommendations will be helpful to you and other people in the system. I very much hope that you'll share the publication of the report amongst your colleagues, and it's great to see such a multidisciplinary audience here today. And I have got some more results for you later on, but I'm sure that you've had enough for me. So I'm going to stop at this point, and hopefully JC will be there and ready to give us her talk. She's stopped being a photograph. She's become a moving image. She's ready to slide share.
Okay, I'm hoping you can see my slides now.
We can. Thank you, JC.
Thank you very much, Sam, for that. That was really interesting and sets the scene really well for this presentation. So I'm speaking on the perinatal optimization toolkits, which has been an initiative that the NNAP and the BAPM have collaborated on over the last 18 months. Just moving on. So perinatal optimization is the process by which we reliably deliver evidence-based interventions to improve preterm outcomes. And the care pathway, which was established by the BAPM Collaborative, refers to those processes or interventions as they occur over time. So as Nick was talking about earlier, they don't just start at the time of birth, but there are several interventions that happen before birth that can improve outcomes. And we describe this pathway as starting really with the prediction of preterm birth, however you predict that, and I'll come to that later on, followed by some antenatal optimization interventions, place of birth, antenatal steroids, magnesium and antibiotics, and finish arguably with around about the time of birth, when we have toolkits on optimal cord management, normothermia and maternal breast milk. And other practices around about the time of birth are recognised as improving preterm outcomes as well. But for the time being, these are the areas in which the BAPM and the NNAP wanted to achieve improvement. And clearly this pathway sits as the remit of the entire perinatal team, and not just for one particular specialty over another. There are cross specialty working involved in each of these different areas. It also sits within a quality context, which has to be optimal really to make sure that we can embed quality improvement well and see the fruits of our efforts. And parents, obviously, their importance from the very, very beginning of pregnancy right through to after birth is so important, particularly in shared decision making. So the BAPM and the NNAP have collaborated on 4 specific toolkits, one starting with antenatal optimization, which was launched last month and which I will be talking about with a main focus today, but also these 3 other ones after birth as well. Normothermy you may already have seen, and that was launched last year. And I'm delighted to say that the maternal breast milk toolkit is going to be launched in the next couple of weeks, and optimal cord management, hopefully before Christmas. I've just seen one of the final drafts of that today, so that's looking exciting. And I want to reassure you all that these toolkits fully align with other national drivers for perinatal optimization and other improvement programs as well. And we've taken a great deal of care to ensure that the message is consistent across organizations, and we haven't duplicated effort, nor ask you to duplicate effort either. So there is an increasing imperative really to ensure a really timely delivery of these interventions. And as such, there's a large number of organizations within the UK and internationally who are now driving antenatal optimization in particular. Whether that's through the setting of standards, whether it's through benchmarking or implementation activity. And the BAPM and NNAP have obviously collaborated on these toolkits, with the BAPM providing the QI resource for clinicians on the front line who want to undertake improvement of these interventions, and the NNAP providing a measurement strategy and benchmarking as well. And since we agreed to this program about 18 months ago, I'm really delighted to say that we have had fantastic input from the Maternity and Neonatal Safety Improvement Programme, MAT-NEO-SIP, who are committed to rolling out implementation of the toolkits over the next year or so, providing support and resource to help units within England get started and embed change. While in Scotland, the Maternity and Children Quality Improvement Collaborative have fully endorsed these toolkits and are putting them alongside their other very excellent resources for improving perinatal optimization. So the purpose of the toolkits really is to provide the why in terms of the evidence base for interventions, the what, so providing some best practice guidance, but I have to say these are not guidelines in themselves. We understand that the solution for different units and different networks can be very different depending on their context and processes and resources and so on. And we very much encourage people to look at the how, so subject-specific QI support that then allows units to choose from almost pick lists of different solutions that really suit their context best, so that's most appropriate for their own barriers to change. In addition to that, the toolkit provides resources, and so does the rest of the BAPM website as well. So you'll see that there are quality pages within the BAPM website now that you can visit. And we have a team of around about 15 to 20 BAPM members who are working on these areas of spotlight on safety. So that's a shared safety learning page that has various resources and improvement stories. The quality improvement toolkits, obviously. There are improvement stories and the QI storyboard, and some of you may already have been able to publish your improvement stories there. And we map these to the quality improvement toolkits as well. And lastly, there's the QI Made Easy section, which is a series of sort of bite-sized tutorials to help guide you and support you through some of the QI methodology that you may come across within the toolkits. So I encourage you all to have a wee dip into the BAPM website. But for now, I want to take you through the antenatal optimization toolkit. All the toolkits are written in the same format so that you become more used to the format over time if you're using several of them. And I want to just take you through the antenatal optimization one. So although it is not a guideline per se, all of the toolkits have some broad brush aims. And for antenatal optimization, this is really all about trying to maximize the number of women who receive the interventions for which they are eligible. And the reason for this is that there is therapeutic time windows for steroids, magnesium and antibiotics, such that if they receive these interventions out with those time periods, the effect may be diminished or absent in fact. So there's a big focus on the accurate prediction of the timing of preterm birth, whether that's through preterm labour or medically indicated preterm birth. And the prediction part of the toolkit is really strong, talks about obviously a detailed history, but using other technologies such as quantitative fetal fibronectin and cervical length, combined in the current QUIP app, although other methodologies are will be available, and in medically indicated birth, placental growth factor, and I'll come to these a little bit later on. But as well as guiding the timing of these pharmacological interventions, accurate prediction is really important in informing in utero transfer, so that we get the right mother to the right place at the right time, so that if she is delivering an extremely preterm infant, that they have the best chances for a good outcome. And I'm just going to talk a little bit about the evidence for you. Firstly, around prediction of preterm birth, we know that women who've got a preterm birth history, that they are more likely to give birth preterm next time around, and it's about 15 to 46% of women will do so who've had a previous preterm birth. But most women who give birth preterm do not have a history of preterm birth, so they will not be picked up by preterm birth surveillance clinics, for example. And so they often present in stages of preterm labour, whether early or late. And so we have to use other technologies to help us understand roughly when they're likely to give birth, so that means we can get them to the right place and give them their interventions. And so at our disposal, there is quantitative fetal fibronectin, which fairly reliably predicts preterm birth, less than 30 weeks. And when you add cervical length to that, and that's a modality that many units do not have, but it refines the predictive ability of quantitative fetal fibronectin and saves around about €500 per patient in terms of admission costs and so on. The QUIP app, and I don't know how well most of you will be familiar with this. Obviously, we have obstetricians and midwives in the audience, but the QUIP app has been developed by Andy Shannon and his team, and it puts together history alongside fetal fibronectin and cervical length to give a prediction of preterm birth within the next 7 days. And when this is used, it has been now validated, shows that it avoids around about 90% of admissions, meaning that you can discharge women quite comfortably if their QUIP percentage is below 5%. In terms of medically indicated birth, the placental growth factor and placental growth factor ratios are a new test that is now endorsed and is being rolled out by the NHS Accelerated Access Programme across NHS England to try and reliably predict preeclampsia in women who are less than 35 weeks. And that's a technology that is being strongly encouraged that units adopt. We need to get out of the habit of thinking that steroids are good for lung maturation. Clearly they do that, but the headline really is that they reduce death by 30%, and there is accumulating evidence that that is as effective in babies who are at extreme preterm gestations as well. Clearly they reduce RDS, but also important morbidities such as intraventricular hemorrhage and necrotizing enterocolitis. And again, the extreme preterm evidence is mounting for benefit in those gestations as well. We've talked about the optimum timing being within 7 days of birth, with a course completed 24 hours before birth. And Sam's just presented data that over 90% of women within the UK who deliver before 34 weeks receive antenatal steroids. But what that measure doesn't show us is how many delivered between 24 hours and 7 days. And the evidence suggests that only about a fifth of women who give birth preterm receive steroids in this time frame, and I think it's about 50% of women who receive steroids at all do not actually deliver at a preterm gestation. So importantly, there is some mortality benefit if steroids are given a little bit closer to birth, but the benefits don't exceed 7 days at all. So it's really important that we're working together with our obstetric and midwifery colleagues to try and develop pathways that ensure that we get timing correct, particularly as repeat courses will reduce respiratory distress syndrome, but they don't reduce mortality. And there is suggestion that they will impact on fetal growth. So again, accurately predict preterm birth rather than having a repeat dosing strategy. It's really important. So magnesium As Sam has already talked about, given within the 24 hours before birth, this reduces the risk of cerebral palsy. We know that I think the national figure is 83%, but really a wide range, 74 to 94%, so 20% difference between units in doing this. Again, there are similar effects across gestations, including seen in the extreme preterm infant as well. And there's a little bit of controversy about whether or not a loading dose is enough or a maintenance infusion has to be given as well. And the evidence to back up the use of a maintenance infusion as well as loading, which is what's recommended in the toolkit, is that the optimal maternal level is achieved at least 4 hours after the loading dose, with the fetal level probably lagging behind by about an hour or so. So it's important to think about that in terms of, I mean, clearly having women on magnesium infusions is important for labour ward capacity and so on, but that is the current national guidance from NICE and also in the Precept programme. So we've gone with that to keep the message consistent. Obviously, antibiotics are important. They're often an afterthought when it comes to established preterm labour, because women, there's an imperative to get magnesium and steroids in as well. But the benefit in treating women who are known to be group B strep positive and who present in preterm labour, the evidence shows that this reduces the risk of group B strep sepsis tenfold. And as we in this country don't know whether women are group B strep positive or not, the guidance is to give that as soon as possible when a woman presents in established labour. In place of birth, we know now from a series of studies, some of them pretty large, that if birth of an extreme preterm infant occurs in a high volume neonatal intensive care setting, that mortality is reduced by around about 50%, and there are other important reductions in necrotising enterocolitis, intraventricular hemorrhage and PVL as well. So again, really important to transfer before birth and not after. So we've kind of put this together in a sort of simple schema for education purposes within the toolkit, just presented the rationale along with the evidence that people can use if they're wanting to educate the wider team. But we also provide some best practice principles as well. We've given 3 of these, and the first one of these is improving awareness. And clearly you cannot give interventions to women to improve outcomes unless they present, and there's probably a bigger piece of work that the BAPM will take on next year on improving awareness, improving societal awareness of preterm birth, the signs of preterm labour, and the beneficial effects of interventions if women can present early enough. But awareness also encompasses primary care with GPs and community midwives being trained about risk factors for preterm birth and the signs of preterm labour. And once women get to secondary care, can they access the care that they need in a timely way? And so these best practice principles and suggestions here are not a mandate that all units have to have all of these different solutions, but there's an encouragement for units to look at their own processes and see which ideas and which solutions may actually work in their own local context. We've talked a lot about improving accuracy of prediction, but just want to highlight it's not all about suspected, threatened and actual preterm labour. There are medically indicated preterm births as well. And in these, both fetal surveillance and maternal surveillance are clearly important to be undertaken as well. The third principle is about improving delivery of antenatal optimisation interventions. And we suggest that units might want to use the mnemonic STAMPED for this, which encompasses the interventions we've talked about already, but puts parents really at the heart of decision making, and an encouragement that a delivery plan that encompasses discussions, intrapartum monitoring, optimal cord management and so on is developed, and that should aid communication between different teams as well. In addressing these principles, there are some recommendations for infrastructure, but again, these are not a mandate. And if units are already got good compliance in specific measures without some of these recommended infrastructure items, they should not necessarily change what they're doing. But we do recommend that each unit should establish leads for antenatal optimization who will help to build a perinatal team culture with shared goals and responsibilities. Systems and triage to expedite assessment of women once they present, training packages, including simulation and rolling out of guidelines, and importantly, a system of exception reporting. And I'm going to come back to that a little bit later on, because the toolkit helps you with exception reporting in terms of a tool that we have developed for you. We've used best practice high-performing units to build these recommendations, and many such units used prescription templates, pre-made administration packs, stickers and checklists to help the users in the front line deliver these interventions promptly and in a streamlined way. Talk about information for parents, obviously, and guide people towards the BAPM Extreme Preterm Framework for Practice, which is got excellent resources for communication for those of us who are consulting with families at risk. The Preterm initiative, which is a regional initiative down in the southwest, it's built around perinatal optimization. Well, they use parent health passports in which various interventions and discussions can be documented, and it's really useful to help aid communication between units if women are being transferred between units, but also as a sort of a holding place for information for the parent themselves. Sam's already talked about place of birth and how about, I think, 75% of babies who are born less than 27 weeks are born in a NICU setting. It's a really complex problem to address with really complex solutions. But we would recommend that networks seek to establish combined maternity and in utero transfer policies, a central referral hub to try and minimize the amount of time that is spent trying to seek COTS. And there are some units who have a policy of auto-acceptance, or some networks that have a policy of auto-acceptance where women are just automatically accepted if they are less than 27 weeks. And mainly that works really well because not all of these women deliver straight away, and so capacity changes in the coming days and they can be accommodated. We talk about the support that is required that for clinicians in district general hospitals, not just in transferring women, but also in the decisions that have to be made in transferring and the discussions that are had, particularly around the extreme preterm infant. So I'm going to put sort of best practice and evidence aside and talk about the improvement journey, which is the same across all of the toolkits, but the examples that are described are different in each. This improvement journey occurs over 5 phases, from defining the problem through to implementing, embedding and sustaining. And it's based on a model that has been developed by the Academic Health Sciences Network. So those of you in NHS England will be well acquainted with this process. So in phase 1, this is where you define the problem, and the toolkit helps you to understand your data, and particularly in the context of national standards and benchmarking. It provides QI tools to help you understand process and context. And here you see a fishbone diagram, but we have other tools such as force field analysis and process mapping that can help you as well. And we provide examples to give you ideas about where to start, etc. We encourage the development of an improvement plan to structure your project using a driver diagram. And the really important areas of this part are the improvement stories that we have sought from high-performing units that we have identified from the NNAP online tool, which you can use yourself to find similar high-performing units in your area, or units that have the similar case mix as you do as well, and learn from them if that's easier. But there's some really nice stories within the document which may give you some ideas and motivation about how and when and how to start. The parent voice runs really strongly through all of the toolkits, and experience stories are really important in helping us really understand the impact of what we're trying to achieve. And we'd urge you really strongly to go and listen to your own parent or your own parents and get feedback from your own users, because although the stories that we present are important, they may not provide the same relevance to you as your own parents would do. In developing a shared purpose, we talk about building a QI team and engaging stakeholders. That's the people on the shop floor who'll be carrying out your change idea. And we're all guilty of working in professional silos from time to time. And I think such is the imperative really for abolishing that kind of way of working and establishing much more functional, collaborative approaches across specialties, that the MatNeoSIP and BAPM are working on a piece of quality work about building a perinatal team culture. And we've started that work now and hope to have that with you by the middle of next year. So look out for that. In phase 3, we encourage you to develop a project charter, not just to detail how your project is going to take place and what measures you're going to use to understand success, but also this can be used as a way of getting the resources that you might need, highlighting to senior management what your requirements are. And a lot of units find this process really helpful in that area. And then in formulating and testing your solutions, we point you to lots of different QI methodologies, but the model for improvement is used ubiquitously in healthcare, and I'm sure all of you are pretty familiar with it. And we give an example here of the three-stage questions that we ask in the model for improvement, and PDSA cycle, small tests of change, and what that might look like in an antenatal optimization setting. Clearly, to be able to measure improvement, you've got to be able to collect data, and we are pretty clear on making sure that we don't increase the data burden for you. We encourage you to use the data that you're already collecting for other organizations and dashboards, etc., and for Badger. But we do provide some additional measures to help you get more granularity on your data. And these are outcome, process, and balancing measures, and we describe the difference between these and what you might want to use should you want to explore your data further. In analysing and displaying your data, we talk about run charts and statistical process control charts, clearly exceptionally important in understanding change. And we provide QI tutorials as well on the BAPM website to help support your understanding of these methodologies. We understand that these types of display can be quite impenetrable for your audience, and so we help you explore how you might modify your data to produce feedback that may be better suited to your wider team and importantly for parents as well. Lastly, in phase 5, we're talking about implementing, embedding, and sustaining. We talk about spread, how you might do that formally and informally. As I've said before, there's a big focus on exception reporting, and I know that the NNAP recommendations are big on this as well. We have provided a tool that units and networks can download and modify for their own local use, which is obviously really important. In understanding barriers and finding solutions to loss of motivation, we describe a whole host of different techniques and solutions that may be helpful for you, including things like making the process easier for your frontline staff using stickers and checklists and stamps, etc. Remarketing your message, so doing away with complex statistics and making your language much more plain for your frontline staff. And again, using parent stories such as this one of a mother of a 27-week gestation baby. Again, very important for the unit where that mother was born to hear how impactful she has found the fact that she received those interventions before birth, and how that she feels that has made her baby healthier and happier. So getting started, you might want to download the BAPM toolkits that exist and look out for the maternal breast milk one and optimal cord management ones later in the month. Start talking about perinatal optimization across your team. Look at your data, understand your processes, build your team. Find solutions that are bespoke for your own local context, and spread the message and embed change within your system. And lastly, look out for the implementation support that's coming from MatNeoSIP in 2021, and that's for those of you in England, the decision-making tool that's going to go along with that, which hopefully will be electronic, which will really help clinicians at the time a woman presents early in labour, and which is alongside parent information as well. And the Building Perinatal Team Culture, as I said, will be coming out next year. it just leaves me to thank the Antenatal Optimization Toolkit group, but indeed all of the toolkit groups that have been involved in this initiative. Without, I think there's something like 60 members or 60 professionals who've been involved in this, along with parent charities as well. And they've brought so much enthusiasm and expertise to the programme. It's been a total privilege to work with them, and I've certainly learned an awful lot. Thank you very much.
Well, thank you very much indeed, JC. That's great. I hope you're going to be able to hang on and answer some questions.
Yeah, sure.
Brilliant. So hopefully it's hard looking at a screen where you're mostly black squares, but I'm believing you're all out there. We hope that you're going to send some questions in. You should have had a message to send them to Oliver Rackham. You can send them to Oliver on the chat. Oliver Rackham, R-A-C-K-H-A-M. I think he should appear on the menu there. With that, because I think Nick's no longer chairing, I think it might be me. I'm going to try and find the other presentation. Not like
I was wondering, because we're 10 minutes ahead of time,
okay,
if we wanted to give everyone a 10-minute break from the computer screen so they can digest what they've taken in and maybe think about some more questions.
Okay, let's have a 5-minute comfort break in order so that we can all finish 5 minutes early. How about that as a compromise solution? Because you're suggesting that some people might need to stretch their legs, so to speak. Yeah. That sounds like an excellent plan. So it's now 15:01, so that gives me 5 minutes to get my presentation up on screen. That should be enough. We'll see you all at 15:06. Thank you very much. Settled in the room. So welcome back, everybody. Sorry for burbling on during the intermission there. It's great to have you back. So this is a little bit of a cheat, as you've gathered, because I am going to talk about the future of NNAP, but I'm really also going to talk about some of the results as well. It'll be even better if I can make my slides advance. There we go. So what I'm going to try and talk about is some updates on how we're working. I'm going to try and show some new ways of presenting the data. And I'm going to show something about putting the measures together in spine plots. And then we'll hopefully be able to have a good free-flowing discussion, for which send your questions to Oliver Rackham on the chat in the usual time-honored Zoom way. So here are some operational updates. The collaborators meeting, we postponed. It was going to be a face-to-face meeting in November last year, and we've put that off until no, not in November, in March, and we've put that off until November next year, by which time we're all hoping to be fully immunized. And we'll be holding that in London. And who knows, we might even have a glass of wine afterwards. So clearly, like everybody else, we've moved all of our meetings online, and we've had the usual learning curve associated with that. It's a strange thing, but I hope you're getting used to it as we're trying to. The 2020 data, we're really going to plan to try to deliver the same methodology, but we understand the results might not be the same because of the impacts of COVID on the way we work. But we're really going to try to measure things in the same way and not give ourselves excuses. But we know that not everything will be quite the same in terms of what we achieve. Hopefully it'll be continuing improvement, but perhaps not all in the same way. So we have identified some outliers in the 2019 data, and some units have been written to. Ask me how I know. And neonatal, and there are slightly less alarm level outliers than there were than there were last year. I'm not sure that that's an enormously big difference. We plan for the 2020 data to use the same methodology. Well, as ever, we welcome your comments and participants about that. But clearly, the significance that's attached to what we measure will be different for 2020 data year. We're continuing to provide results to support GIRF, the Getting It Right First Time program, CQC, National Clinical Advisory Bureau, is that, and a whole variety of other bodies that are interested in the data that we work with. We're continuing to link with Magnesium and BAPM, as we've just been hearing about. And really, it's a bit pompous, but I like to call that unifying the measurement conversation. So hopefully we're not all trying to measure things with slightly different yardsticks. Thinking about the quarterly reporting, that's ongoing. As you know, for the 2020 data, you should have had your Q3 recently. And we could answer questions about that in due course. And we're continuing to develop measures. Well, we're not developing any new measures, but we want to keep communicating with you. We're always open to new measure ideas, but we've got quite a few. So I want to talk about some clinical reporting updates. Firstly, I want to talk about the preterm brain injury measure. So of the outcomes I showed you at the very beginning, I mentioned IVH and PVL as I think what it was abbreviated to in the slide. We've been working with an expert group for well over a year to describe an outcome measure of what you might call IVH stroke PVL. This has been to an expert group, and we had a sort of external expert consultation group. We've been back and forth to the methodology and dataset group and the NNAP project board with respect to that. We've implemented the measure on the BadgerNet system. It's got wide support, so we're very excited to be implementing this for the 2021 data year. The measure itself, I'm not going to go over in great detail, but it only applies to babies that are less than 32 weeks. And we're trying to evaluate IVH, in which we include hemorrhagic bronchial infarction, or HPI if you like, post-hemorrhagic ventricular dilatation, and cystic PVL. The definitions for all of those measures are already embedded in Badger and have been for some weeks. The data will, of course, require validation because depending on how you clean your data already, in my neonatal unit, I know that I need to go and check whether that's been entered correctly. And so I'll be doing that at the end of the year. Well, I'll probably do it as the year goes by. So make sure that we're describing any abnormalities that we do see correctly. So I've got some new formats and it's barely new analysis, but I'll try to take you through those in the following categories. And I'm going to finish up by discussing the mortality results and the use of matching in respect to that. So I didn't talk about the results of the parental attendance at consultant ward rounds in the first talk. Above is a graphic that I stole earlier from NNAP online. It'll be very difficult to read unless you get very close to the screen. But that's Bradford. So in the top row, you see light blue for the proportion of babies whose parents attended at least one ward round at any time during the baby's stay. And we got about just over 80% in that. And that compares reasonably to the comparators that are below. But there's a pretty strong feeling from parent representatives that that's not really good enough. Just being able to attend a single consultant ward round and that count as a pass for an individual baby doesn't really feel very descriptive. And so below what you can see is the data for Bradford looking at, in this case, we get about 87% in the period analyzed here. But what we thought would be helpful would be to present alongside that measure the proportion of days where a consultant ward round occurred and a parent was present. And that's a much lower proportion. It's about 1 in 5 rather than 4 out of 5. And so we thought that would be a useful thing to present alongside that measure. It's a bit more descriptive for those units like my own that are trying to be on a journey to making parents involved in ward rounds as part of parental partnership in care. So that's the thing we're planning to do differently, and that's already come out in the Q3 report. So maternal breast milk feeding, we've got some measures of that, as you know, and the measures are: does a baby who's born at less than 32 weeks gestational age receive any of their own mother's milk on the 14th day of life? And does a baby born at less than 32 weeks receive any of the mother's own milk at discharge? So I might skip forward to breast milk feeding at discharge. As a community, we're not great at this. There hasn't been much change over time. It's about 6 out of 10. There's not much change since 2013. And we all think that that's concerning, and it's difficult to know what to do about it. That's part of the reason for introducing the breast milk measure at 14 days. But actually, we thought that it would be more helpful to look at, to try to present graphical representations. So I should have checked whether people can see my mouse. Jess, I don't know if you're on mute. Can you see my mouse or not? It's just
yes, I can.
You can see the mouse, fantastic. Okay, so hopefully that means everyone out there can see the mouse. So if we just were to take this bottom right-hand panel on the slide I'm now showing, this graph is describing all the babies of less than 32 weeks over 90 days on the horizontal axis in a given neonatal network. And you can see in this slide that the majority of babies fall into this darker green, so are receiving at least some breast milk early on, and even by 3 weeks of age are receiving some breast milk. The light grey underneath is babies who receive only formula milk on a given day. And you can see that that is it's larger in the northern region than it is in the panel above, which represents the network London, North Central and North East. And then the light green is babies who've been discharged, who were receiving some breast milk on their last day in hospital. And the light grey is babies who were discharged receiving only formula milk on their last day in hospital. You can see that gradually gets wider. So in general, at a network level, I think you'd probably agree that the shape of these is all quite similar. However, if you compare northern, so London, North Central and East, I think you would find it easy to be convinced that in the northern region, where I did so much of my training, lived for so much of my life, the proportion of babies who are either inpatients receiving breast milk or have been discharged, having been receiving breast milk on the day of discharge, is considerably less than half, whereas in London, North Central and East, it's considerably more than half. And so in that regard, that would appear to be success for London, North Central and North East. We hope that these figures might be useful to neonatal units and perhaps also networks. And so these figures will be available on the NNAP online website, but I believe they're not yet available because we're just fine-tuning. So apologies for that. There's been a slight communication error, but they will be there very shortly, and we will email out when they're available. So we hope they'll be useful. We really welcome feedback about that. A lot of work's gone into trying to get this right and get it agreed. Hopefully it will be useful. So as a take home for the 14-day breast milk measure, good news, 8 out of 10 babies get some of the mother's own milk at 14 days of age. But there's quite a variation between 88, so 3 out of 4 versus plays 9 out of 10. So that doesn't reflect very well on all of the neonatal networks. Worryingly, from the perspective of the key findings group, neonatal intensive care units do not, on average, have higher mother's own milk use than local neonatal units and special care units. And this is felt to be a worry, given that neonatal intensive care units are looking after the babies who've got most to gain. The higher risk babies have got the most to gain from being breast milk exposed. There is a wide variation in mother's own milk units at unit level between 68 and 92%, but only 2 neonatal intensive units can be identified as low outliers for what that's worth. So hopefully looking at your own figures will be helpful in identifying where in the patient journey it is that you're successful and where that you want to try to influence change. For my own neonatal unit, we do well at starting babies on breast milk, but we're not as successful as we would like at keeping them on breast milk as the weeks go by. So there are, as you'd expect, some recommendations around that. I'm not going to go through these in great detail, but these are designed to be helpful. They're very carefully thought about, and we hope they'll be useful to you. So nurse staffing, that's never a thing to worry about, is it? As you know, the NNAP has 3 measures of nurse staffing. In particular, what proportion of nursing shifts are numerically staffed according to the guidelines, and what proportion of shifts have sufficient qualified in speciality according to the guidelines. And there's a 3rd measure: how many additional nursing shifts would you need to have worked? In general, people have tended to want to say to us that neonatal intensive care units have the problem and that other units don't have the problem. I hope this figure makes clear that that's not true. So along the horizontal axis, we have the size of the neonatal unit, and that's based on the amount of babies that they look after. This is how many nursing shifts would be required to look after the babies within that neonatal unit if it was staffed appropriately for every shift. And then on the vertical axis, we have the proportion for each unit of shifts that are staffed according to the guidelines. I hope that you would be convinced that for units of between 10 and 15,000 annual workload, that there's a wide variety amongst NICUs, that some NICUs are apparently staffed adequately almost all the time, and there are neonatal intensive care units that are apparently staffed inadequately, adequately only about a third of the time. So assuming that this hospital is an outlier, and put the data in, which is what we believe. There is a strong sense, there's a little bit of relationship, but in general, special care units have slightly better staffing, and there's a structural size reason for that. But in general, it's not just about the size of the units. Small units have problematic staffing. Large units have relatively good staffing. The take home from this is that neonatal intensive care, that neonatal units have staffing that is significantly below recommended levels. Only 2/3 of shifts are numerically staffed to the recommendations. That's a little bit better than 2018, but only a little bit better, and is described by our key findings group as a serious cause for concern. And I don't mean that in a joking fashion, that the use of the word serious is intended to add real emphasis. NICUs do experience the highest proportion of shifts not staffed to recommendations, but and the NICUs that will have the patients who are the most unwell, so that is clearly a concern. And if anything, the qualified and speciality adherence, which I haven't talked about in any detail, appears to be worsening within the intensive care units. So it's not great. So recommendations. NNAP says that the Departments of Health in England, Scotland and Wales should ensure that sufficient resources are available for the education and employment of suitably trained professionals to meet the guidelines. And that universities and Health Education England, or equivalent bodies in the developed nations, should consider revising, renewing and standardizing the models of specialist neonatal nursing education. And that's because we hope that staffing will improve and the proportion of specialist nurses will improve. But that will only be a meaningful change if everybody understands what specialist nursing qualifications actually means. So there's work to do there for the system. It's felt that neonatal units and networks should prioritize their data quality assurance, because there's clearly a very small number of units where the data is not right. It's a very small number of units, but there are some. We think that units and networks should monitor adherence to this and develop action plans. And I imagine that many neonatal units, certainly my own, has an action plan to address any deficits in their staffing and skill mix. So that's nurse staffing. That's not a small thing. I've talked about lots of different measures, and you'll be sick to death of listening to me. I've only got one more measure to go, but before that, we want to show you something that we call spine plots. Now, this is shamelessly stolen from another audit, but we hope it might be helpful to you. What this does, and I'm showing you here Yorkshire and Humber, but mostly because it was to hand, but also because people don't like me publicizing their data. I'm showing you here Yorkshire and the Humber. And the black midline here is the national rate. And for this particular measure, antenatal steroids, you can see here the black dot representing Yorkshire and Humber's position shows that Yorkshire and Humber are good at antenatal steroids, if you like. The grey bar represents the expected range, if you like. There is no expected range for nurse staffing for statistical reasons, but hopefully this will give colleagues in the Yorkshire and Humber a bit of a feel for what it is like in their neonatal network. And we felt that by comparing networks that might be useful. So that networks might get a bit of a feel for where they're strong, and Thames Valley and Wessex are strong at everything, nearly everything. And give networks an idea of their sort of priority areas for improvement, and where they're strong, where they're not so strong. And these are available in the report, which you can download today. I know I've checked. There are also unit level spline plots. These look just marginally different. And you can bring up, I'm showing you Bradford's for obvious reasons, not because we're proud of all the results. But here we see, you could bring those up, and I could put up another units next to this. I can put up to 4 units in one panel. And that will show us where we're relatively strong and where our areas of improvement are. And these are not a surprise to us, and we have action plans to deal with, to be honest, all of those. I'm pleased to say. So we hope this is useful to you. We welcome feedback about it. We hope that you might want to compare yourselves to units that you want to be like, or units that you don't want to be like, and see where your strengths and weaknesses are. So finally, I'm going to talk about mortality, and then I'm going to get off and do some questions. This is the audit measure, as you know, is what is the mortality? Does a baby born at less than 32 weeks gestation age die before discharge home, or 44 weeks post-menstrual age, whichever occurs sooner? And of course, some of the babies die. So here is the caterpillar plot for neonatal networks. And this shows for babies of less than 32 weeks that about 1 in 20, just over 5%. It's about 1 in 20 die. You can see that there is some variation by neonatal network. There are a couple of neonatal networks where the uncertainty around their mortality is well below the national average. And at the other end of the plot, there are neonatal networks whose dots are above the average, and the confidence intervals you can interpret for yourself. So this is pretty worrying. It looks as though crude mortality varies from just over about 4.5% to around 9%. So that's almost a doubling, isn't it? Well, it is a doubling. So this is very concerning. We've seen this before in the previous years, and we know that it's a matter of concern. That when we presented this data previously, we did a different form of risk adjustment. We've changed the form of risk adjustment to the so-called matching analysis, as I showed you with the BPD data. So just to repeat, this asks the question, how would the babies from, say, my own neonatal network have got on based on their characteristics if they'd been looked after in the whole country? And then it takes the difference between the measured mortality and the mortality that statistically would have occurred had they been looked after all over the country, and you generate a treatment effect. And positive is not good. So we can see here that the networks are in pretty much the same order. If you look in detail in the report, there are some neonatal networks that are low outliers, that have treatment effect that is well below 0, and where the confidence interval, the measurement of uncertainty, doesn't cross 0. So that tells us that being looked after in those neonatal networks appears to be a real advantage to their babies. So in effect, we all want to be like it is in London, North Central and North East and East of England. There are other neonatal networks. There's another neonatal network, which is a high outlier, has high outlying mortality. And these are just facts, they're neutral. We hope that this is useful information to neonatal networks. You can do the same analysis for babies of less than 28 weeks. So then on the vertical axis, the rate of mortality changes. So it goes from about 5% to about 15%, it's about 1 in 7. But you see exactly, or not exactly, but very similar gradient in mortality. And again, the mortality is double in some neonatal networks what it is in others. You can look at a treatment effect and you see the same phenomenon that I was describing previously. So that this is a concern. And this should prompt neonatal networks to engage in this issue. And we've thought carefully about what they might do. Suggestion is that neonatal networks and their constituent neonatal units should, following a review of their local mortality results, take action to consider whether a review of their network structure, their flows, their clinical guidelines, or their staffing might be helpful. And to consider whether a QI approach to the appropriate delivery of evidence-based strategies like timely antenatal steroids, deferred cord clamping, avoiding hypothermia, and the early management of respiratory disease, whether a QI approach to those evidence-based strategies will be helpful. And to make sure, so networks and units should be making sure that locally delivered, externally supported multidisciplinary death reviews, including data from PMRT, informs their network governance and clinical practice, unit clinical practice. And further, the recommendations consensus group felt that the patient safety team and NHS improvement and equivalent bodies in the developed nations could and should facilitate national dissemination of learning, because it's no good having these lessons if they're not shared. So national dissemination of learning from mortality reviews. So that's me, I'm nearly off. The NNAP has been granted an extension year from April 2021 to 2022. That's a COVID phenomenon. We want to, we are going to consult with HQIP and with you all on whether it would be helpful or possible or helpful to try to publish some of the data that I've shown you earlier in the year. It will probably still take as long as it has done this year to produce a report with the key findings, recommendations, outlier analysis, and all of that. But the suggestion is that we might be able to separate some of the report, some of the data publication from the report publication, although there's much to clarify about that. And there'll be further changes in the way that we work in the coming year, but we'll try to keep you informed of those. So with that, I'm going to get off and stop sharing so that I can see people. Hopefully Oliver is somewhere out there and is going to curate some questions. I hope some of you have written some questions to him.
Yep. So thanks very much, Sam. That was excellent. So as always, a really good in-depth knowledge of the topic and also of the data itself. So we have had quite a lot of questions.
Great.
So that's good. So I'll try and go through them in some kind of structure. They are mostly probably headed your way, but I'm sure that Julie Claire can help you if you've got anything. So I'll struggle now, everyone who's listening, to pick up any new questions, but I'll just see whether I can, if anything else comes through. So I think we start off, I'll go through it in a kind of timeline. So if we start off with antenatally, we've got a few things. So it started off with some thanks, which was very nice from Karen Lloyd about the work that everyone put into Precept and seeing that come through. So it's nice to have some good news stories like the increase in magnesium. So that was just a thank you rather than a question. There's a question from Sajid Nezrangadi who said, we would expect steroids and magnesium to go hand in hand in terms of improvement, but it doesn't seem to. Had you noticed that, and do you have any explanation?
I wasn't really expecting, Sajid, that rates of antenatal steroids would go up much further than they already have. Whereas magnesium, it was very clear to me, back from when Bill and I wrote about that in archives a few years ago, that there was a lot of improvement to occur. And, you know, a lot of things have happened. I suppose it's more than 3 or 4 years ago since we wrote that article. But so I think there's been huge potential for improvement in magnesium. I think there's probably a bit more potential for improvement in magnesium, but I don't think Karen would be upset to hear me say that I'm not convinced that we'll get the national average to 95%, or even much over 90%. But I do think there's a lot of individual patient gain to be accrued by, if you don't know if the woman's going to deliver in the next 10 minutes, getting arrangements made to give you a magnesium. I do think there's a real issue, as Jude Claire and many others in the sort of national perinatal team are saying, around the timeliness. And we really think that NNAP, the NNAP measure of antenatal steroids, we think should continue. But we think maternity need to get a measure up and running of timely administration of antenatal steroids, rather than trying to build and extend the neonatal data flow further into the world of maternity. So I expect to see new measures of antenatal steroid timeliness that further help us as a perinatal team, not just us, to do better with respect to steroids.
Okay, thanks. So I suppose you've started to answer the next question that was there, which was, can we control for unavoidable missed targets? So the examples that the person gave were the place of birth for women who just come in and deliver it straight away, or magnesium was the other thing somebody comes in. So I suppose you've started to answer that.
So we I don't think we can control for it in the analysis. I think we've always got to be sensible clinicians when we look at data about our clinical practice and not be defensive about it. I think there's a strong the woman who comes in delivers, and it's arguable that she couldn't be prevented from delivering in the wrong place, and then there was no time to give her antibiotics, there was no time to give her magnesium. But in fact, in places that I've worked, when we looked back at how the admissions occurred, in fact, that woman's been to and fro and had features of preterm labour. So I think there's a lot in the antenatal optimization toolkit that Julie Clare talked about. Maybe we should ask Julie that we can do to address even apparently cases with apparently inevitable features. We'll never get the rates of antenatal steroids to 100%, in my opinion, and I don't think we'll ever get the rates of magnesium to 100%, in my opinion. But I'm sure there's more we can do, particularly on magnesium. Julie Clare, you probably got a comment on that.
Yeah, I really sympathise with people where women just come in and deliver, but I think when you unpick these and when you really case review them, there are certainly probably around a half where the woman has had symptoms and signs for some time beforehand and she's just not presented early enough. So I think a lot of the work that we're hoping to take forward with BAPAM over the next 12 months is really about improving parental understanding and awareness, perhaps even on a sort of public health campaign scale, to try and get women to labour wards much more quickly. And I think while people talk about it being unavoidable, I think we just have to be really careful when we say that we have actually explored avoidable factors, such as, and it may be that women have been in and out of hospital. It may be that we've not used an accurate prediction tool to predict preterm labour, and whether or not those could be the solutions for your unit or not.
Yeah, I think that's a really good answer from both of you, actually. And I think that thing about things we call unavoidable, the point of things like peer review or comparison across and within networks, is that what you might think is standard practice could be poor practice or outstanding practice in other places. So that's good. There's another question on magnesium, just while we're on antenatal factors, which was from Nick Bishop. So I probably should ask it, even though I think he's left us. Is that there have been reports of bone disease in babies after receiving magnesium. So is there a maximum dose or a maximum duration that should be recommended for the intervention?
Oh, that's definitely a Julie Clare Becker question. And I understood not. Nick and I have talked about this previously, but Julie Clare, you probably got a more informed answer.
So there is evidence for, or guidance for, the maximum dose that I think is given within NICE, but you can find it in I think it's Appendix 3 of the Antenatal Optimization Toolkit. The dose, the actual dose actually escapes me, but I think it might be something like 3 grams in total.
So sorry, I think Karen's just come on a chat saying she can answer that.
Okay, good.
But I think she can't, because I don't think she's allowed to speak on the way it's set up. So Karen, I think you'll have to type it.
Then that's fine. But again, it comes down to accurate prediction, doesn't it? And trying to get those methodologies really tight so that you know when a woman is going to deliver or not.
I suspect Karen was going to say that that's based on really quite limited case reports from the US, as I remember. But Jess might be able to unmute her. But let's go on to another question and come back.
Okay, so she's put in the chat, it only happens with long courses and very high doses. So I'm taking that to mean that the way it's used in standard practice doesn't cause it. And maybe people could contact Karen to get more detailed answers. So we'll just move on for time, just to try and get a few. There's been a few people have asked about this, so I'll jump to this, which is about feeding. And on the graphs and in the data, there doesn't seem to be a mention for donor milk. So there were 2 ways it was worded. One was when donor milk is included, it counts as mixed feeding, and other people talking about your graph saying donor milk doesn't count. Can you just explain that?
So the graphs that I've shown today are about mother's own milk. And I suspect that we all agree that the objective is for the baby to receive mother's own milk, and that donor milk is a substitute. There are people who think it's a poor substitute. There are people who think it's a good substitute or a not so poor substitute, but I think everybody would accept it's a substitute. So we're not about trying to measure substitute performance. We're trying to measure what may certainly feel, and in some areas of the country, most of the areas of the country I've worked in professionally, to be honest, it feels quite hard to address. But that's not to say that it's not worth trying. So donor milk's not included in the enumerators in that respect. It clearly has a part to play where mother's own milk isn't available, when no mother's own milk is available. Interestingly, there's a trial proposed about use of mother's own milk to try to encourage women, as part of a package to try to encourage women to use their own milk. But we wouldn't be. I wouldn't be in equipoise about using donor milk instead of formula for certain babies. I think that's not an area of equipoise.
Okay, thanks. And on that topic, since we're talking about feeding and a risk of NEC as well as the other outcomes, there's a question from Lawrence Smile who said, could you check with NNAP leads if they use probiotics and see if there's any correlation with NEC rate variation?
Thanks, Lawrence. That'd be a great registrar project, wouldn't it? We have done that in the past, but not. I could almost shout to Lawrence over in Leeds, but that would be a great telephone questionnaire project. In fact, we've got some telephone questionnaire data. So if you want to contact me offline about that, we did a survey a little while ago.
And then I suppose this is sort of related to that in terms of the topic, which is about NEC. And its relation to death. So there's some, I think, come from a couple of people, and then also this relates to other measures other than NEC. So you mentioned that NEC, I think, is inversely related to death. Has that been formally analysed, or is that just an association that's noted?
No, it's not been. It's definitely not formally analysed, and it's something that came up as we looked at the data at the key finding stage. One of the thoughts that we had was that we might want to, so you'll have noticed that when we present data on BPD, we don't actually present data on BPD despite what my slide said, it's BPD or death, and that we might want to present NEC alongside a competing outcome of death. So it was really with that in mind. It was a kind of, to some extent, a recommendation to the audit. But thank you. Again, that'd be an interesting thing to look at. We always have to distinguish between research and audit, and that's always a tricky old stuff. But that would be really interesting to look at further, wouldn't it?
Yeah, and I suppose it's linked to another question, which was, which I presume you've given the answer to, but we're interested to see what your thoughts are about mortality versus other measures. So we measure quite a lot of processes like temperature, steroids, but also some outcomes like sepsis. And in terms of, are they related to mortality, especially for outliers? And do those measures have any link? Because presumably that's the point of NNAP, is to find things that can improve other outcomes.
Yeah, so I think it's whenever I do any activity, I think it's quite a good idea to remind ourselves what it's for. I think the point of NNAP is to help units and networks, so audit users, I sometimes say, to facilitate quality improvement. The point of NNAP is not to work out whether it's NEC or BPD that causes more death, or NEC or late onset infection that causes more death. There are lots of other epidemiologists to do that. I think so we're not really about that working out where these mechanisms are intersect. For us, the importance of competing outcomes is about providing fair measurement. For NEC, the issue about NEC and mortality, we might need to do both. But we really welcome correspondence about that, and members of the methodology data set group will no doubt, and new members hopefully joining us. Jess, are we still looking for members of the methodology data set group, or is that now closed?
I think that's closed. We've had several people
Fantastic.
join us.
We'll look forward to that. Oliver.
Yeah, good. So I suppose on that is the question of measures and making sure the measures are right. So we've got a question about the BPD measure saying that it's a very wide spectrum. So you may be in a trickle of oxygen, or you may be on high frequency ventilation and you're still in the same group. Has there been any thought to using a different classification like the NICHD and then doing the analysis?
So yes, there's been thought about that, and we've overtly decided not to. There's a clear feeling that oxygen at 36 weeks is the right way to measure BPD in a surveillance context. It clearly encompasses a range of pathologies, from life-threatening bronchopulmonary dysplasia that is going to be life-limiting, through to a pretty trivial oxygen requirement that goes away quite quickly. It's about having something that we can measure reliably. I think there's, NNAP is not the definitive answer to all research questions about BPD, but hopefully some of the data that is collected because we do the work will be useful to others.
Okay. Just on that note, I was hoping someone else was going to ask this question, so rather than pretend they did, this is from me. BPD and mortality are obviously adverse outcomes, whereas giving magnesium, steroids, having normothermia are good outcomes, but we still report them in that way round, which means we end up with this strange treatment effect, that a positive treatment effect is a bad thing. What are your thoughts on whether we should, given that people are just getting to grips with it, flip those around?
So Oliver, I know you have a strong opinion about this, and there are lots of other people who don't hold that opinion. We had a quite a robust debate. I don't mean you and I, in the group about whether a treatment effect should be expressed positively or negatively. So for those on the call who aren't, so we say that when you're looked after in a neonatal unit, that in effect results in you being more likely to being diagnosed with an adverse outcome, death or BPD in this case, then we say that that's a positive treatment effect, as in that that increases the rate of that outcome. The point that Oliver raises has come up particularly is in presenting these in the spine plots. And if you look at the spine plots on an NNAP online or in the report, they've been flipped around. So all the good outcomes are to one side. I'm particularly interested to get comments from people about the utility or otherwise of the spine plots. When I saw them for NNAP online, National Maternity and Perinatal Audit online, I thought they were a really helpful way of summarizing lots of different audit measures in a single panel. And I found them very persuasive for my own trust and from sort of a presentational perspective. I realize I'm not necessarily the average user. I think we've improved on the NMPA ones, in particular, making them all go in one direction. But I'm keen to get feedback about the use of those. So please do write to me. There is almost only one Sam audit, although there are two on Twitter, but I've blocked the other one. So please do get in touch.
So I suppose that's an important thing to say about NNAP, isn't it? That it's everybody's audit. It's not the audit of a few people, and the program is not of a few people. It's really to try and get all stakeholders to have their say, and where things could be done differently or better, then we really do need to know about that. So do flood Sam's inbox, please.
Can I just quickly take the time to thank some people? So I think that the college have done a brilliant job in terms of building a coalition of people across sort of what you could call stakeholder bodies in a bit of jargon. But I think that's a real strength of the program, that it relates to lots and lots of different bodies who have an interest in neonatal care, and I think that's made the NNAP a much stronger thing. I wanted to thank particularly Jess, who's been the project manager, but also Simon and Duncan, who have Simon and Tom, who have been instrumental in delivering the reports. It's been a great deal of work done and our colleagues at NDAO, Kaylee and Nick, who do the heavy data lifting, you could say. So there's a lot of people involved and mostly invisible, but I'm absolutely delighted to answer emails and do that. We do that quite a lot, and it's very stimulating. And most importantly, for your perspective, has resulted in lots of change to the audit. So we do take the feedback seriously, which is not to say that every idea that you come up with is necessarily going to make it to the top of the list. Even Oliver can't achieve that.
Oh, definitely not. And you know, I think it is good. There are discussions, and I'm perfect. You know, there are definitely two views to most of these questions, which is good that we get consensus. There's still a few things to get through. There's a number of people have asked about mortality, treatment effects, and in particular about how deprivation is taken into account. I'm going to just try and summarize a few questions on that just to make sure, and then I might come back to you if I don't think they're all answered. So does treatment effect take into account deprivation has been asked a few times.
Yeah.
Or is it just baby specific things? And then, yeah, we'll answer that first and then we'll come to this.
Great question, and thank you for raising it. No is the answer to your question. So deprivation is not currently in what you might have regarded as an adjustment model. It's not really an adjustment model, but the listed matching variables. And it had been intended that would occur, and it hasn't occurred. We are uncomfortable about that, regretful about it, and we will put it right. But it won't be this year. We won't be correcting this. Well, it's not correct, incorrect. But we hope to be able to deliver that for the 2020 data report published in 2021.
Okay, so I suppose that's saying there isn't any analysis on deprivation.
That's correct. The list of variables that are in the model has been slightly amended from the matching variables we used last year, and it is published in the report, so you can go away and look at it.
Yeah. And a few people have commented that looking at the net, I think you can see it from the network plots, is that there does seem to be a north-south divide in terms of mortality. Have we got any comment on that?
It's grim up north, as my mother used to say. I don't think we know why there is variation. There is an articulate representative who is on the call of a neonatal network with not so good mortality. And I suppose I'm also a representative, although not articulate one, of a neonatal network with not so good mortality. In general, I think it's true to say that doing some form of case mix adjustment is useful because it makes people believe the data, makes people believe the raw data. The adjustments that case mix adjustment that we've done makes relatively little difference to the take-home message for mortality and actually for BPD. I would encourage us not to get too distracted by measurement effect and to try to think about why it might be. It's not for NNAP to answer the question of why mortality is higher in some places than others. There are, however, I hope, useful recommendations we can make about how people can check for obvious things. And I know of neonatal networks that have gone away and acted already on those recommendations, that are forming evidence-based review groups that are making sure dissemination of their learning from mortality reviews, those kinds of things.
Okay, good. So these are all quite links actually. But it's slightly different. So BAPM guidance is now available for babies born at 22 weeks gestation. Are there plans for NNAP to change the gestational age for relevant measures such as mortality so that we can have national reporting?
So we already have changed the gestation threshold for antenatal steroids. And if anything, the rate of administration went up. We don't have plans to change the mortality threshold at the moment because even at 23 weeks, the available data suggests that there's a lot of variation in the rates of admitted babies. And so the key thing for us is not to say by excluding certain categories of babies from measurement doesn't mean say we don't value those babies. It's only that we want to concentrate on making sure that we're doing a fair comparison, a fair test, as they say in school science, doing an apples to apples comparison. So for mortality, not thinking of changing the threshold at the moment. It's no doubt a thing we'll keep under review in the methodology dataset group.
Okay, there's just a few comments coming through just while we're talking, and a couple useful ones from Karen Lloyd, who said the NCMD report on deprivation looks at effects for perinatal causes of death and also measures mortality at all gestations, suggesting that there is a big effect. I suppose, like you say, there are different reasons that different reports are coming out.
So I think the only I'm not as familiar with the NCMD reporting that Karen's talking about as she is, because she's in charge of it. What I would say is that it's very well known that deprived families are more likely to have a preterm baby. Of course, preterm babies are much more likely to die. It's very well known that on a population level, deprived communities experience more death from prematurity. What's not clear is that a given 23-weeker is more likely to die if his parents are from a deprived background. And in fact, there is some evidence of the reverse. So it's quite complicated and very difficult to get across in this kind of discussion. But I do think we ought to improve deprivation in the model. It was not intentional that didn't happen this year, but I'm not sure it's going to change the message big style.
Okay, we're running out of time. We've just got a couple more questions I'd like to get in. So one is about parental involvement. So, I wouldn't want to miss that one out. And a comment that parents being there on the ward round is a very crude measure and doesn't really represent parental involvement. Are there any plans to try and to amend that?
So we always welcome well thought out plans to do measurement differently. Prior to Oliver's involvement with NNAP, we worked with parent representatives who suggested the ward round measure. And for all that it is crude, and as I've shown today, I think our analysis of it has been crude, it is nonetheless, it represents an area of improvement that Bliss and our parents were very articulate and persuasive advocates for inclusion of that and measurement of that. And there are definitely neonatal units in the country that just don't believe in having parents on the ward round. And I'm not in a position to argue about that. I think that having parents on the ward round is part of parental partnership, and it's part of a humanity of care that is totally different to when I started in neonatal 20 years ago. So I'm very enthusiastic about that as a measurement opportunity. Quite how, it's a bit like the parental consultation question. People ask us, well, what was said? What was the content? Who had the conversation? And clearly we could try to measure that stuff, but in a way that is meaningful to compare between units. I'm a little bit skeptical about that, and I haven't yet seen a proposal that makes obvious sense to me as to how it could deliver it. But that wasn't on this occasion, Sam. That wasn't from me. That was I believe it
from John McIntyre this time. So, but I would have pretended if no one else had asked. And I suppose so. Suggestions from parents and from users of the system would be very valued, wouldn't they?
Yeah, absolutely.
There's just again on. Slightly different, I suppose, on data collection is that as people move to electronic patient records, lots of people are using things like Epic or Cerner. What do you think that's going to do to data collection as there may be moves from Badgernet?
So our position has been that we're going to need to wait and see, and we hope that we'll be able to continue to measure. I hope that the way that we will continue to run an NAP effectively is because people will value it, not because it's in the service specification and people told they've got to do it, not because the neonatal network tells them they've got to do it, but because they can actually find some utility in the results. And I'm hopeful that will be the case. The key thing from my perspective is not where the data comes from, but that it is useful and that we provide effective reporting. So I'm not so worried about the kind of things that could happen. And we've dealt with challenges in the past, and we'll deal with challenges in the future, no doubt.
Yeah, good. So I suppose it's the thing about making sure it's useful, and then it should be data that people are collecting anyway, wherever they collect it. And I mean, there's one view that as you move to EPRs, it should become easier because there'll be even less duplication. Just, I think I'm just going to try and squeeze one more question in, just because it might be for both of you to answer, which is about away from premature babies and talking about elective cesarean section. The RCOG recommends steroids up until 38+6. NICE don't mention it, and there's some evidence that antenatal steroids may be associated with long-term risks such as behavioural and mental health issues. Have either of you got any thoughts on that?
I've definitely got thoughts, but I'm sure JC's got much wiser and more intelligent thoughts than I have.
Definitely that is not the case. As I understand, the RCOG guidance is being updated, and I don't think it has been published as yet. So I think the more recent guidance may be different to that, as far as I understand.
My understanding
we do
is
have obstetricians in the audience, so maybe they could.
Well, while we're unmuting them, can you name one, JC, and Jess might be able to unmute them? My understanding is that the guidance that whoever asked the question is referring to is actually no longer on the RCOG website. And I think there's a lot of concern about giving antenatal steroids at term. And I'm not at all, as yet unconvinced, let's put it that way, that it's the right thing to do. The more mature the baby, the less persuasive the case. The only data suggests that it reduces neonatal admission, and not by very much. So I'm unconvinced about that, and I think that's a likely direction of change. Is there an obstetrician who actually knows the answer?
So if an obstetrician can really quickly type that in to their chat, then I can and give some answers. So it was, you know, as you say, it was quite rightly put in the question that it's very old guidance.
Yeah.
So, but otherwise, I think we're at time. So I think we probably need to wrap up the questions there.
As clinical lead, even though I was officer for audits, I'm going to thank you all for participating and thank you all for your engagement. You've been on the biggest online meeting I've ever participated in, and we're super grateful to you for all your work putting the data in and making clinical change that is improving the lives of babies. And I think there's plenty of evidence that if you look back in our audit over time. So I'm really grateful to you for your engagement. Please do write to the audit or to me. And I'd like to thank the people who organised it, particularly Jess, but many. We'll see you all in the flesh soon in November 2021, albeit hopefully if not before then. So a Zoom wave from me. Bye.